Good evening, everyone. My name is Lucas. I will present our ground of oncology department. I'm a resident of the second year. My preceptor was Dr. Guilherme, and the head of the division is Dr. Melina Moraes. Our ground starts with our patient, a 40-year-old female patient, Black, born and raised in São Paulo, that came to our emergency department complaining about decrease of visual acuity on her left eye that started 5 months before this appointment and got worse 2 months before that date. And on the last week before this first appointment, she did develop pain on her left eye. She went to another ophthalmology that said to her that she had a tumor inside of her eye, and then she came to our emergency department. She denied any other symptoms, systemic or ocular. Her past clinical ophthalmological familiar history was unremarkable, and she didn't use any medication. On her ophthalmological exam of the right eye, it was unremarkable, and on her left eye, she had a visual acuity of hand motion. She had a hyperemia of conjunctiva of two crosses, and she had an intraocular pressure of 36 millimeters of mercury. On the fundoscopy, it was possible to see a subretinal pigmented mass localized temporally, and it was associated with a diffuse retinal detachment. So in this first moment, we did the hypothesis of a choroidal melanoma on her left eye. We started some hypotensive medications orally and topic on the left eye, requested an ocular ultrasound, and sent this patient to an appointment at our ocular oncology department. She did the ocular ultrasound. Here we have the axial length that is normal in both eyes. And here on her left eye, on the transversal incidence, we can see on the temporal aspect a subretinal lesion that has a lateral diameter of 21 millimeters and a thickness of 15 millimeters and an anterior-posterior diameter of 18 millimeters. That is we can relate it with that first hypothesis that we have done. Associated with this, we had a diffuse retinal detachment, and we had this image on the sclera that the person that did the ultrasound suggested that could be an invasion of the sclera. So she went to the appointment in our oncology department. They agreed with our hypothesis of choroidal melanoma on her left eye. They maintained the medical treatment, requested a clinical evaluation with our team of clinical oncology, and requested a pre-surgical evaluation with the proposal of enucleation of the left eye, and requested a reevaluation in 2 weeks. But with 1 week, the patient came back to our emergency department. She was using all the medications that we have proposed, and she was complaining about a severe pain on her left eye associated with swelling and decreased visual acuity that started 1 day before this appointment. I'll show you photos of both eyes, but the right eye was unremarkable. On her left eye, she had a vision of no light perception. Before it was hand motion. I'll show you photos of the anterior by microscopy. Her intraocular pressure was impossible to evaluate with Goldman, but it was apparently hypertonic, and the fundoscopy was impossible. So here on our right eye, we can see normal eyelids and eyelashes, a clear cornea. We have a mild hyperemic conjunctiva. We can't see here, but she had a formed anterior chamber with no chamber reaction. We have a pharmacological mitosis, and the patient is phakic. But on the left eye, we have this image. We have this whitish discharge on her eyelids. We have this diffuse chemosis all around the conjunctiva that is hyperemic. And it's hard to evaluate the cornea and the anterior segment here. But here on this cut on the slit lamp, we can see that she's almost athalamic. And when she closed her eyes, we have a lot of exposure of tissue, even with the closure of the eye. So we've done some diagnostic hypotheses here, and we thought about an acute left orbital inflammation. And first, we thought about an infectious involvement of the orbit, like a postseptal cellulitis. It's hard to think about this hypothesis because it was really fast. It developed in 1-2 days, and she didn't have any symptoms systemically, like fever or other symptoms. We also thought about an aseptic cellulitis. That's something that we'll discuss more broadly on the last slides, but it's due to a rapid growth of the tumor and it starts to necrosis in some points because of the feeding vessels. They can't feed all the tumor that grows very fast, and it launches some inflammatory cytokines and get this kind of inflammation. We can also think about a direct invasion of the orbit by the tumor that she already had. We already had this diagnosis that she had this melanoma. Other less probable is traumatic etiology. She didn't say to her that to us that she had any trauma. We could think about an orbital emphysema or a retrobulbar hemorrhage or idiopathic, but here it's not quite a possible hypothesis. So thinking about mainly to differentiate this infectious and aseptic orbital cellulitis, we requested some laboratory ancillary exams and requested head and orbit images. Here we chose magnetic resonance with contrast. She's done just general images, just general exams. Her hemogram and other blood exams were unremarkable. She didn't have leukocytosis. And here we have the orbital magnetic resonance. Here on the sequence T1, we have this hypersignal lesion inside of her left eye, associated with this V-shaped lesion that is related with a retinal detachment. And we also have this proptosis of the left eye. After the injection of the gadolinium, we can see that the lesion has a mild enhancement, as well as the tissues around the orbit, the soft tissues, that denotes that inflammation that we've seen clinically. When we see the actual T2 and flare, we can see that the lesion is hypointensive in both of the sequences. And with the diffusion, we don't have any restriction of diffusion. So with these images and these exams, we thought about a choroidal melanoma on her left eye that had a complication with an aseptic orbital cellulitis. That is something that I will discuss more on the last slides. So we proposed the discontinuation of the hypotensive medications because she was with no light perception. We prescribed on her left eye atropine, 1 drop every 12 hours, and dexamethasone every 6 hours. We started oral prednisolone, and we requested an urgent post-surgical evaluation to perform the enucleation of her left eye. She came back after 2 weeks to our reevaluation, and she referred an improvement of pain and upper swelling of her left eye. The post-surgical evaluation was done, and it was authorized by our team. She was using the medications that we proposed for her. And here we have the aspect of her left eye after 2 weeks of this topical treatment and systemic treatment with prednisolone. We can see that there's still a hyperemic conjunctiva, but we don't have that chemosis that we've seen before. And we have this disorganization of the anterior chamber. We can see here when we do the cut with the slit lamp that all the tissues are dislocated forward, probably due to the growth of the tumor, and it's almost at limit here. So we performed the enucleation of her left eye here. I have some photos of the intraoperatory moments. We can see that the eye was quite similar to that last photo that I've shown you before. And here we have some steps of the surgery. It performed without any complications. She here had a reevaluation 1.5 months after the surgery. Of course, she was evaluated in between this time, but she referred here a mild pain on her left orbit, but she denied any ocular or systemic symptoms. She was using an association of ciprofloxacin and dexamethasone on her left eye and oral prednisone. Here we can see the aspect of an ophthalmic cavity. She's still using the scleral lens, but we have here the wound is quite well. We don't have any sign of descent or infection. Here we have the cut, and the patient also are following to adaptive process. Here you can see the histopathological exam of the patient. We have this very pigmented lesion that we've seen before on our fundoscopy, and here we have the images of the pathology with this tumor with some black and very pigmented cells. And we can see here these white spaces among the cells that denotes places where the tumor had necrosis. And I will discuss on the next slides that it's very important for the physiopathology of the complication that she had, and also for the aggressive of the tumor. It also showed invasion of the sclera and perivascular invasion, but it didn't show invasion of the perineural tissues. The subtype, histological subtype of the tumor was epithelioid cells, and we will discuss a little bit on the next slides. That's the most aggressive one. She was also evaluated by our clinical oncology team. She denied any symptoms systemically. She had done an abdominal and pelvic magnetic resonance and an abdominal ultrasound that didn't show any significant alterations. So we have here a staging of the TNM, a PT3A that is due to the size of the tumor, and MX because we don't have any evidence of involvement of this different tissues. So she's still being followed by both of the things, the clinical oncology and the ocular oncology. So I would like to discuss a little bit now about the ocular melanoma. And here we have that the choroidal melanoma is the most common kind of uveal melanoma. We can have lots of symptoms in the presentation of this tumor. Most of them will be presenting with blurred or distorted vision, but we can have visual field loss. We can have flashes of light, change in iris color, and we can even have the asymptomatic ones that are around 30% of the cases. This presentation of an inflammation that we've seen here, it's present around 2 to 5% of the patient. Usually it will be presented as this hyperpigmented lesion on the posterior pole supraretinal that can have a lot of shapes. We can have mushroom, dome shape, and this diffuse one that I've shown here on this image. We can have these orange pigments on the surface of the lesion, and we also can have this amelanotic presentation that is more rare. Here I brought a review about this presentation as melanoma mimicking an orbital cellulitis. We call it septic cellulitis or pseudo-orbital cellulitis. And it's not common, but it will be presented as an acute orbital involvement with proptosis, pain, visual loss, and restricted extraocular movements. The histology of the tumor that can be presented as this complication, we have all the different subtypes of histological tumor. Here I've just brought some images to show that some complementary evaluation, it's important on the melanoma. Here we have an autofluorescence that can show this hyper autofluorescence due to the lipofuscin. The OCT can show us some subretinal fluid, and the most important here ciliary evaluation is the ultrasound that can show us on the A scan that medium or low inside reflectiveness with a peak on the top of the lesion and then a decrease of reflectiveness. And we can also see the shape and measure the size of the lesion more precisely. Here we have that mnemonic that is classic to find small ocular melanoma doing image to differentiate some hyperpigmented lesions. So we have thickness more than 2 millimeters, subretinal fluid, symptoms, orange pigment on the surface of the lesion, margins, or it's a lesion near the disc, and we have a diameter of more than 5 millimeters. And if we have more of these features, it will be a higher probability to be an ocular melanoma. I brought this image here to show that the cellular environment of the tumor is quite different. We can have cells with different shapes. So we can categorize here 3 types of histological subtypes of the tumor. So we have this spindle cell, that is the spindle cell subtype. When we have more than 90% of the cells with this shape, it is a fusiform cell. We can have the epithelioid one, when we have more than 90% of this cell that is a cuboid one. That was the one of our patient and is the most aggressive one. And here we can have the mixed one that is the most common when we have both spindle cells and epithelioid cells. Thinking about the management, we can have we can think about the ocular treatment that can be expected if the patient doesn't have a high life expectancy, but it's not the rule here, just some specific cases. Basically, we can have two kinds of treatment here. We have brachytherapy, when we can use to small tumors, some usually until 10 millimeters, and the surgery, the most common one is the enucleation, but we can also have this iteration when we have a diffuse invasion of the orbit tissues. And of course, we have the metastasis, the most common ones are for the liver, and we can think about local regional therapy with ablation, embolic arterial embolization, and we can have also systemic therapy with chemotherapy or immunotherapy. But even with these different kinds of approaches, the prognosis of the patients with systemic metastasis are very poor. This is our reference, and thank you so much for the attention. I'm open for the doubts. Thank you.
Okay, Lucas, very good. Your presentation. And let me see if Dr. Guilherme has some remarks. Are you here?
English or Portuguese?
We have the VTs here, if you can see, but whatever you prefer. Okay.
Congratulations, Lucas. Very nice case, a very rare presentation of the ocular melanoma. So 2 points we have to see that are different from the usual scenario. The first one is that it's very important to do an ultrasound in the probabilities of the orbital cellulitis, because if we solve the patient at this point, it would be very difficult to find the problem. And the other point is that the general treatment for the orbital cellulitis is with antibiotics. And in this case, we did not use antibiotics. The treatment was surgery. And we had to reduce the inflammation of this eye because this surgery would be impossible. And the morbidity of the patient and the difficulty to reconstruct the cavity would lead to a very worse life for the patient. So very nice.
And how long was the treatment with steroids before the surgery?
2 weeks.
2 weeks. The only thing that I would say about the ultrasound, we had one ultrasound before the patient had
Ultrasound before.
this worsening.
Yes.
Yes. And maybe that area that was thought to be extension, this could be some collection of fluid beginning.
Mhm.
Like, I don't know. But it was not an extension because we saw it in enucleation. There was no interrupted sclera. Okay. That's a very good case. That's it. Thank you very much. Any comments from our side here? Peter? Any comments? If you want. Okay. So now we have, I'd like to call Mariana. Mariana is a fellow at Glaucoma and Glaucoma. Yeah. To present a case, perspectives of glaucoma.
So good evening, everybody. I'll present the neuro-ophthalmology division case. My preceptor and head of the division is Ana Laura, and my name is Mariana. I'm a neuro-ophthalmology and glaucoma fellow. So our case is about a 23-year-old male patient. He's white, student. He's born and raised in São Paulo. He was already following up in the hematology service because he had an acute lymphoblastic leukemia that was diagnosed in October 2018. And he already underwent chemotherapy, and he had a central nervous system's recurrence in January of the last year. And he also had a stem cell transplantation in April 2022. And he was taking prednisolone 60 milligrams and once a daily. And he was taking also infectious prophylaxis such as cyclovir, sulfamethoxazole, trimethoprim, and voriconazole. And he denied any ophthalmologic or family history. So he came for the hematology team complaining of a painless vision loss perception in the left eye in July 2023. And then he was hospitalized with the hematology team because of this, to investigate this vision loss. And they asked for ophthalmology in consult, which was performed by the emergency room division. So his ophthalmologic exam was, he had his best corrected visual acuity in the right eye was 20/20, and in the left eye was counting fingers at 2 meters. He had no ptosis, no proptosis, and he had preserved ocular motility. His pupil examination showed a RAPD in the left eye. He had normal anterior biomicroscopy, no chamber reaction. His IOP was also normal, was 14 in both eyes. And his fundus examination, he had a pink optic disc with sharp margins, a cupped disc ratio of 0.3, and normal vessels, normal macula, and attached retina. And in his left eye, he had a swelling of this optic nerve, and he had vessel tortuosity, normal macula, and normal retina, the peripheral retina. And here we can compare the two optic discs. So for the diagnostic hypothesis, we have a immunocompromised young male patient with ALL, CNS recurrence, and transplantation in 2022. And he came with a complaint of painless vision loss in the left eye with his optic disc swelling in the left eye. So we thought about infiltrative causes such as ALL recurrence, or maybe inflammatory cases such as optic neuritis, and also infectious causes because he was immunocompromised. And he was young and he didn't have any risk factors for ischemic optic neuropathy, or we didn't think about also uveitis. And so for the management, the hematology team during hospitalization, the vital signs were normal, and laboratory were also normal. ESR and CRP were normal. The infectious serology exam showed no infection, and his cerebral spinal fluid showed high lymphocyte profile and no tumor cells. And the MRI, I'll show the pictures. So here, the axial cut T2, we can see a posterior pole flattening, an optic nerve blurring in the left eye. And this Dixon cut, we can see an optic nerve blurring in the left eye. And here in the flare, we can see a optic nerve thickening in the whole extension. Also near the chiasm. This coronal stir, we can see a left optic nerve blurring. We can see here the right nerve is, we can see the sheets very clear, but not in the left side. And it becomes normal next to the chiasm. And this spur, we can see also posterior pole flattening, optic nerve tortuosity, and optic nerve enhancement. So for the management, the hematology team asked for our in-consult, and they asked for neurology in-consult also. And they opted to treat the patient with post-therapy, 5 days with methylprednisolone, 1 gram per day, between July 22nd and July 26th. And he was medically discharged in July 27th, and referred to the neuro-ophthalmology clinic. So he came to our appointment at the neuro-ophthalmology clinic 5 days after the discharge. He said the vision was clearer in the left eye. He was counting fingers before, and now he was 20/30, and we could perform a OCT in both eyes for this patient, but the visual field was not available at the time. So here we can see the OCT of the right eye. We can see temporal and nasal retinal fiber loss. And in this papillomacular bundle loss also in the right eye. Here we can see these radial lines showing the posterior pole with normal curvature. And here in the left eye, we can see here in the double hump graph that he has this optic nerve swelling. So we didn't show any loss of fibers because of the swelling. And here the ganglion cells, we can show it shows a superior loss in the left eye. And here, if we compare the radial lines from the right eye and the left eye, we can see that the curvature is a little bit less in the left eye. We can see like a flattening of the posterior pole of the left eye. So based on the MRI and OCT images, neuro-ophthalmology hypothesis still was infiltrative cause. So we contacted hematology and asked for a new evaluation by the neurology team and asked the patient to come back in 2 weeks. He came back in 2 weeks saying that he was having a progressive worsening of vision in the left eye. His visual acuity now was no light perception. And the response from the hematology team was they decided to perform a PET-CT scan, which we are still waiting. And the fundus examination and OCT and MRI I'll show in the next slides. So here we can see that the fundus examination of the right eye was still normal. And in the left eye, we can see a worsening of the swelling and more paler in this inferior area of the optic nerve in the left eye, and also intraretinal hemorrhages in the posterior pole and also in the peripheral retina that show that he was having like a central vein occlusion in this left eye. So here we can compare the fundus exam in the ER in consult and the recent evaluation showing the worsening of the swelling and the retinal vein occlusion. The OCT still showed thickening of the nerve fiber layers of the left eye and diffuse loss of the ganglion cells. Here we can see still there's anteriorization of the optic nerve and also in the macula, here, the macula and the optic nerve. So here are the new MRI cuts. We can still see the optic nerve blurring in the left eye. And we can see a worsening of the posterior pole flattening, optic nerve blurring also. And in this diffusion weighted image, we can see an optic nerve enhancement of the left eye, which suggests that there was a lot of cells next to the optic disc. And in this XLT2, we can see a worsening of the posterior pole, flattening optic nerve tortuosity. And now the optic nerve was close to the medial rectus also. Here in the spur image, we can compare the XLT2 from the first MRI and the recent one. You can see that it was more tortuous. And here the spur image. So in order to initiate the proper treatment for the LLA CNS infiltration, hematology team asked for an optic nerve biopsy to confirm the hypothesis. So we brought here this paper from the neuro-oncology practice. The title is Optic Neuropathy in the Context of Leukemia or Lymphoma, Diagnostic Approach to a Neuro-Oncology Emergency, which was published by Myers and colleagues and was made in Canada. So they say that the optic nerve is susceptible to recurrence because the posterior pole is a pharmacologic sanctuary and is usually unaffected by chemotherapy, which our patient underwent last year. And they revealed isolated cases of infiltrative optic neuropathy from 1996 to 2015. And they had 36 cases of leukemia. Half of the cases were like our patient, like ALL. And in these leukemia cases, they found malignant cells in the cerebrospinal fluid in 64% of cases, and neuroimage was normal in 43% of cases. And the most common alteration was thickening with or without enhancement of the optic nerve. And they also proposed a diagnostic flowchart. So if this patient with leukemia comes with optic neuropathy, we should ask immediately for CBC, ESR, CRP, MRI, and ophthalmology, hematology or oncology, and neurology consults. And if there is no diagnosis, we should ask for infectious causes, CSF, paraneoplastic antibodies, and flow cytometry. And if there's still no diagnosis, we should ask for a biopsy of the optic nerve. Thank you for the attention.
Would you like to comment, Anna? Stay closer.
Well, hi, everybody. Thank you, Marianne, for your excellent presentation. We decided to present this case tonight because it has some points that we can discuss how to differentiate inflammatory from an infiltrative optic neuritis. First, the appearance of the optic nerve at MRI. We observed thickening of the optic nerve, more important than signal enhancement. It's not usual to see inflammatory optic neuritis. Second, the flattening of the posterior pole was observed in the MRI and the OCTs, suggesting that something could be pushing the eye globe from behind, and we see it in patients with intracranial hypertension. And finally, the good response to steroids that can be a little bit tricky because inflammatory can respond very well, and infiltrative can also respond very well at the beginning. But then our patient experienced very severe worsening of the visual acuity, along with the central venous retinal central occlusion, and it's not seen in patients with inflammatory optic neuritis. So we took all this information together with our patient's medical history. Then we decided to talk to the hematology team and said, hi, we think that this is SPEC. And they said, yes, but the cerebral spinal fluid is normal. So we need you to prove that the disease is bad because the chemotherapy will be really, really, really aggressive for this patient, even life-threatening. And we need this proof. So patients be prepared for the optional biopsy, and we hope it can be performed as soon as possible. So we can confirm the hypothesis. And if we have time, I would like to ask Dr. Macintosh if you have any or had any experience in cases like that.
This is a great case, very rare. Two questions. I love your discussion around this case already, but I have two questions and thoughts. One is, can you show us the OCT picture again?
Yeah, sure.
First,
No, maybe the second.
Second.
Yeah, I want to look at, specifically what I want to look at is Brooks membrane, because this is something that I use when I'm looking at patients with idiopathic intracranial hypertension. That pressure from behind pushes Brooks membrane anteriorly. And that just might be another helpful clue again, that something from behind is pushing forward, as you mentioned. I couldn't tell if I saw that or not.
Maybe
Yes,
here, right?
yeah, there you see, right, so that's pushing Brooks membrane, so again, there's a posterior pressure,
Yeah.
exactly as you described. My other comment is about the spinal tap, and even in the paper that you presented, like 64% of those did have a positive LP. So I think the fact that your first spinal tap didn't have tumor cells in it doesn't mean that
The
there's
next
not
one.
a
Yeah.
tumor there.
Yeah.
We know that the spinal tap, you're sampling a part of the body that's very remote from where the tumor actually is, and it's a high likelihood that the first 1, 2, maybe even 3 spinal taps could be falsely negative.
Yeah.
So, you're still waiting for the biopsy.
Yes.
Perhaps another spinal tap. If you're doing the biopsy, I mean, that's the best solution. But one negative spinal tap wouldn't convince me that it's not cancer.
But you need to convince the
Yeah.
Hematology, yeah. Yeah, they don't want to.
Now, a doubt from someone that's not in the neurotechnology field. I would like to know if the choroid is also infiltrated in these cases. Could be.
Doesn't seem like it, but not sure. From the OCT?
OCT, you cannot tell.
Yeah,
It's not good for choroids. So,
yeah, I don't think.
I think maybe ultrasound.
Maybe,
yeah.
Yeah.
Yes.
maybe we can ask for ultrasound, yeah.
So now we have resident from UIC, Michael Chen. Sorry.
I don't think we got that.
Just need it.
Because the value is share, yes, to share the speed. No, there's only, there's nothing like, just like a photo. Yeah, you could send the.
Yeah. It's
Like I said, it's that's I do want to see.
Yeah, sure. It's there. Also.
I can do it. It's USB-C.
Yes.
If that's up.
All right, I guess I'll get started. So I'm Michael. I'm one of the second year residents at UIC in Chicago. I just want to thank everybody for having us here. I've only been here for 1 day so far, and it's been a great experience. Definitely have seen a lot of pathology that we don't usually get to see over in Chicago. So I'm looking forward to the rest of the week and all the interesting things I'll be able to see here. So we're also presenting a neuro-ophthalmology case today. Don't have any financial disclosures to talk about. Let's just jump right into the case. We have this 35-year-old male. He had a history of retinal detachment in his right eye that had been repaired with a buccal and vitrectomy about 3 years prior to presentation. And he came to our emergency room, this was around about a year ago now to the day, with painful vision loss in his left eye for 3 days. He was worried that he had another retinal detachment, but the story took a different turn. So the story that he gave us was that he woke up one morning and had persistent severe blurry vision, and there was pain with eye movements. On ophthalmic review of systems, he denied any other symptoms like redness, flashes, diplopia, and he didn't have any prior trauma to this onset. And then on review of neurologic symptoms, he denied any headache, photophobia, transient visual obscurations, pulse tinnitus. We obtained some more history. He did have a past medical history of obstructive sleep apnea, and he was relatively obese. And then in terms of his eye history, he had that detachment that we already discussed. And that was the only surgery he's ever had as well. He did endorse to us a family history of primary lateral sclerosis in his father. So that kind of set off some thoughts of maybe an autoimmune process potentially. And then his mother had non-Hodgkin lymphoma. And then in terms of his social history, he was a former smoker, but he had quit a long time ago. His vision in the right eye was very good, 20/20, pressure, everything was normal in the right eye. However, in the left eye, you could see here clearly, his vision was count fingers at 30 centimeters, and he did have an APD. And because of that visual acuity, we weren't able to really obtain a color vision. His slit lamp exam was unremarkable. We didn't see anything unusual in the anterior segment. But looking at the back of the eye, in that left eye, he had grade 2 Friesen scale disc edema without any heme or pallor associated with it. And the retina looked fine. And then the right eye, he had his changes from surgery. So at this point, just want to kind of list the unilateral disc edema differential diagnosis. Given the presentation that he came in with, the top of our differential certainly was optic neuritis. And we have a whole host of different etiologies, including these autoimmune conditions, other inflammatory conditions, infectious conditions, as well as post-infectious or post-vaccination associated optic neuritis. And then, of course, idiopathic optic neuritis is something to consider once everything else has been ruled out. Another thing we could think about is anterior ischemic optic neuropathy, arteritic or non-arteritic, given his sleep apnea and obese habitus, but he was relatively young for these conditions. IIH certainly could be considered, compressive optic neuropathy, neuroretinitis, and then more rare things, papillophlebitis, hypertensive papillitis. So we approached this differential first by obtaining MRI of the orbits and the brain. And the orbits were significant for this relatively subtle finding here of a enhancing lesion very anterior in the nerve, essentially right where the nerve was inserting into the globe in that left eye. The brain, the MRI of the brain was unremarkable. We didn't see any demyelination. Also obtained a venogram, which didn't show any venous thromboses. We obtained a neurology consult as well, just to see what input they had, given this family history of primary lateral sclerosis as well. They performed the full neurological exam, which was normal. They recommended getting a CTA head and neck to look for a dissection or aneurysm or other intracranial pathology, more of the vascular type, which was negative as well. And then we also obtained an MRI of his spine to look for other demyelinating lesions, which was also negative. We obtained a pretty thorough lab workup, but most of the things that we were hoping to look for ended up being negative, including all these antibodies for different autoimmune, neurologic, as well as systemic conditions. What did come back positive was ESR and CRP, suggestive of some kind of inflammation, but this could have also been clouded by the fact that he ended up testing positive for COVID. Though he was asymptomatic at the time, that certainly could have influenced these non-specific inflammatory markers. He was found to be very deficient in vitamin D, again, another non-specific thing. He had some subclinical hypothyroidism. He was pre-diabetic, and then a non-specific IgG elevation, but this was in the serum, not in the CSF. So given all of this, we admitted him and decided to start treatment with IV methylprednisolone for this optic neuritis of an unknown etiology at this point. When we admitted him, the initial exam, we had a count finger vision, but quickly the next day he had already decreased to hand motion vision. By the second day after that, he had actually become NLP, so a very, very rapid deterioration in his vision. So just a day after starting IV methylprednisolone, high-dose steroids, we decided to switch to Plex instead, or rather to do Plex concomitantly with the high-dose steroids. At this point, the neurology team tried to perform a lumbar puncture for us to get some CSF and do more testing there, but it was unsuccessful after multiple tries. We finally got one on the third day. His vision at this point still remained NLP, but we can take a look at his CSF studies. The only positive results that came back were non-specific elevation of myelin basic protein and slightly elevated glucose. But interestingly, we tested for all these infectious and autoimmune conditions, which all ended up being negative, both in the serum and the CSF. Ultimately, we, during the first initial inpatient course, finished the course of high-dose steroids and Plex, but his vision remained NLP at that point, about 2 weeks into his stay. On the last day, we sent out labs for a cell-based assay for aquaporin 4 and MOG antibodies to Mayo Clinic, and we discharged him home. We had planned to see him in a few weeks, but before he even got back to us, he was admitted elsewhere now for optic neuritis episode in the right eye. Similar presentation, but the vision was reportedly not as bad. I think they got 20/60. We don't have the exact records from the outside hospital. He was admitted there. They got IV steroids on board again, did not do Plex this time, and discharged him on oral prednisolone, high dose of 60 milligrams. And he came to clinic a few days after the discharge from the other hospital. And here, finally seeing him in clinic, we were able to get some better testing, and we confirmed he truly had some kind of an attack on his right eye now with this visual field showing a deficit. However, his vision in that right eye wasn't affected that much. It was 20/40. And interestingly, we see that his left eye vision now actually had improved about a month after he was first discharged from our hospital with NLP vision. Now he was count fingers. On the exam, looking at the nerves, we could see there was temporal pallor on the right nerve, and then the left nerve had diffuse pallor now. At this point, we presumed a seronegative NMO as a diagnosis, given that all our testing at this point had been negative, but from the MRI and the clinical setting and these visual fields, we could tell he clearly had a rapid sequential onset of bilateral optic neuritis. Here we have a Goldman of his left eye, not the most reliable, but just a baseline for us. So we continued him on the high-dose steroids, came back a month later. Vision in the right eye had now improved, 20/25 from 20/40. Left eye remained count fingers. And we saw that there was an improvement in his visual field in the right eye. So at this point, we decided, let's try to taper the steroids down. We don't want him to be on steroids chronically, and he'd already been on it for a little over a month at that point, at 60 milligrams. Got a better field of the left eye. So I want to take a quick break from the clinical course at this point, just to talk about atypical optic neuritis, since that was what we've been seeing so far, and the working diagnosis was a seronegative NMO spectrum disease. So there's a number of different etiologies. We already discussed NMO, MOG. There's CRIMP5 associated, so more on the paraneoplastic side of things, as well as sarcoid, and then common infectious etiologies for atypical optic neuritis include syphilis and TB. Just like as I described in our patient, it's generally characterized by more rapid and severe bilateral or sequential onset vision loss. And oftentimes the prognosis is poor and the visual recovery is poor relative to a typical optic neuritis, which is generally associated with multiple sclerosis. Interestingly, there's a study that was done looking at seropositive and seronegative NMO, which is possibly more relevant to our patient here. They reported on 175 patients, the majority of which were seropositive. And they found that in the seropositive group, there was a higher ratio of females compared to the seronegative group, where there were still more females, but at a much lower ratio. The seronegative NMO patients were more likely to have bilateral optic neuritis by quite a significant percentage compared to the seropositive group. And all the patients, whether they were seropositive or negative, were treated with IV methylprednisolone, plasmapheresis, PO steroids, and then some of them ultimately received a steroid-sparing agent and through rituximab, and they found that there was no significant difference in the visual outcomes between these two groups. Although the study wasn't originally intended to be powered for that, it was more actually from our neurology colleagues. And overall, the complete remission was about a third of patients. And this was found to be about the same between two groups. And then most patients experienced some partial remission, but even up to 18% had no remission at all. Now to go back to our patient, so where we left off was that his vision was improving, his visual fields were improving. We decided to taper down the steroids. However, a month later, having gone down to only just 50 milligrams from 60, he returned to us with a worse visual field in the right eye, although the overall vision was still stable. At this point, we were concerned about a relapse in his optic neuritis. So we discussed with neurology about switching to a steroid-sparing agent, as it seemed likely that we would need more immunosuppression for a longer term. However, given that there wasn't a very certain diagnosis at this point, neurology was hesitant to start rituximab, and they decided instead to have him go through another course of IVIG instead at this point. Here's his left eye, relatively stable. And we've also got just a CT here showing atrophic changes after the optic neuritis episodes. Fast forward a few months, we actually didn't see him for a little bit, and he had been on the full dose, 60 milligrams of oral steroids at this whole time. There was a very dramatic turn of events in May, so about 3 months later. He presented to an outside emergency room for right lower extremity edema. He said it actually had been going on for a few months, but he didn't really think too much of it. They did an ultrasound and some other scans, and they found lymphadenopathy in his right lower quadrant and in the inguinal region. And based on that imaging, they got a fine needle aspiration biopsy of the lymph node, which showed a metastatic germ cell tumor. So very rare cancer. And the full workup was done. They did ultrasound of his testicles. They did a PET CT. The testicular ultrasound found an extratesticular mass in the right hemiscrotum, and some hydrocele and varicoceles. The PET CT showed the lymph nodes were hypermetabolic, but interestingly, they didn't see any hypermetabolic activity in that extratesticular mass in the right hemiscrotum. But just given the histologic findings on the lymph from the lymph nodes and this mass in the scrotum, the diagnosis was made of a germ cell tumor, and he was started on chemotherapy for this tumor. So now the question is, was there a perineoplastic process going on this whole time? So talk a little bit more, and I mentioned this at the beginning as part of the differential for the unilateral disc edema and the atypical optic neuritis. CRIMP5 associated optic neuritis become a pretty well-described subtype of optic neuritis in recent literature. CRIMP5 protein itself is a collapsin response mediator. It's expressed in the developing nervous system. It's found both in peripheral and central nervous system cells, including oligodendrocytes, peripheral nerve axons. You can find it in the retina as well. And so far, most of the literature around this has mostly reported on patients with small cell lung cancer. There have been a few cases more recently that reported papillary thyroid carcinoma and thymoma, but through our literature review, we weren't able to find any cases that were associated with a germ cell tumor. There's an interesting case series that was published this year, and there have been a number over the past 2 decades or so as well. But this one was just published earlier this year. It's a 5-patient case series out of Beijing. And they looked at these 5 patients, 4 of which were female. Majority were middle to older in life, so a little different from our patient. The clinical characteristics were very different from our patient. They had painless simultaneous bilateral or sequential onset, ranging from 20/20 to count fingers, and all of them had nerve edema on exam. Majority of these patients had vitritis or retinitis or uveitis associated with this, as you can see in the pictures, especially the FA here characterizes it quite well, which if you're going off of this, our patient doesn't quite exactly fit this case series. He had painful vision loss, and he didn't have any other inflammation in his eyes other than that nerve itself. The majority of these patients also had a associated neurological manifestation, including area postrema syndrome, myelopathy, polyradicular neuropathy, and 80% of them had enhancement on their MRI imaging, either of the nerve itself or the perineural sheath. Interestingly, the 2 case reports case series that had been published before this one all reported negative enhancements on their imaging. And of these 5 patients, 3 of them received IV methylprednisolone. 2 of these 3 had visual acuity improvements. And then ultimately, all the patients were stable after they had some kind of intervention of the primary malignancy, which was either surgery or chemotherapy. And this was the case series where there was the thymoma and the papillary thyroid carcinoma. The other three were small cell lung carcinoma. So going back to our patient again, we sent off a perineoplastic panel looking at CRIM5 as well as a whole host of other perineoplastic antibodies that have been described, not just for optic neuritis, but for other systemic manifestations of perineoplastic disease. And these all came back negative. So then our question was, how sensitive and specific is this test? And it's a send-out test in Mayo Clinic. So we discussed with the neuro-ophthalmologist there, Dr. John Chen, and he told us should have a pretty good sensitivity and specificity for CRIM5 autoimmunity. So really this left us kind of scratching our heads. What is this diagnosis now? Well, we have so much negative testing. Do we go back to seronegative NMO? So on his most recent follow-up about 2 weeks ago, he had finished the chemotherapy for the germ cell tumor. His vision was stable, 20/20 in the right eye, count fingers in the left eye. Remains to have a APD in the left eye, color vision is stable, and the nerves look the same as they have been. And another thought that Dr. McIntosh had gotten from his feedback from other neuro-ophthalmologists after posting about this case was getting some of these antiphospholipid cardiolipin antibodies, although they've been indeterminate so far, so we're not really sure what to do with that at this point. But given that he had relative stability after chemotherapy and this steroid taper, the question now is maybe we can think of it as a perineoplastics thing. You can see his visual fields are very stable, his exam is very stable. So we're still debating between whether it's a seronegative NMO in the context of all these negative things, or is it a perineoplastic process in the context of him being stable after completing chemotherapy and now actually being able to taper his steroids down to 25 milligrams, whereas in the past, even bringing it down to 50 milligrams, he was unable to tolerate that. Recently, another study talked about seroconversion for patients who were seronegative NMO, and a very, very low rate among almost a little over 9,000 patients that were initially seronegative. Only 0.3% of them seroconverted. And this was around, on average, around 9 months from the initial aquaporin test. And then conversely, among 900 or almost 1,000 seropositive patients, 11% of them became negative, but then half of those 11% eventually went back positive again. So there certainly is some flipping between seropositivity and negativity, but it's extremely rare for a seronegative patient to become seropositive. And our patient, we tested on day one, we tested on day 3 after having already received some steroids. So the concern at first was, were we suppressing the response there and getting a false negative? But then at 3 months, we retested, and at 10 months, we retested, and they've been negative. So I think we're safe to say that it's seronegative. However, this doesn't really help us to decide what our final diagnosis is. So at this point, he's been on steroids for 10 months or so. And certainly he's starting to develop elevated IOP, cataracts. We're sending him for bone scans. He was already pre-diabetic to begin with. Now he's hypertensive as well. So we ideally would like to get him onto steroid sparing therapy as soon as we can. But we're still working with neurology and oncology to really decide what's the safest route forward with this. Ultimately, kind of just reviewing what we talked about today, differential for atypical optic neuritis includes mostly autoimmune conditions, but there's some infectious conditions as well. And it's important to consider CRIM5 and other paraneoplastic etiologies on your differential for atypical optic neuritis, especially in the context of seronegativity and poor response to steroid taper. But ultimately, the ideal would be to get patients off of steroids to avoid the long-term sequelae. Thank you.
Great case. Would you like to make a comment?
Michael, great presentation. I don't know. I mean, I think you covered it all. And in the end, I think we still don't know for sure. But I think the thing that is most interesting to me is that we've now treated this cancer. We've tapered him lower on steroid than we've ever had him, and he remains stable. We have tested the NMO antibody repeatedly, and as you pointed out in those data, we probably didn't need to do that. We know that sensitivity specificity is good, and if whatever your first answer is, that's probably the real answer. We've now tested it repeatedly, that remains negative. But I know he doesn't fit the mold entirely, but he did have disc edema, which is not typical of NMO. And the enhancement that you showed us was somewhat subtle, which maybe is consistent with what we might have seen, especially in some of the older studies that talked about, you don't really see any at all.
Right.
Because typically NMO has quite noticeable enhancement. You just didn't ever have that. So I would love to hear if you have any experience or ideas about this. Yeah.
Once he was treated for the cancer and he is stable, it's a great idea just let him without going for steroids and see what happens.
That's where we're going. I think I'm a little bit nervous to just stop it quickly. As I said, 25, that's the lowest we've had him on. So I'm doing that. And I think in the next couple of months, I'll have him off.
And then after a you maybe test again for any more.
Yeah.
No steroids.
Right. Because is that having some effect on it? Maybe. Yeah.
Which is can always be a seronegative enemy also.
It can.
Very difficult.
Yeah.
Very difficult. You don't do test again. I have some friends stop
Yeah.
always danger, like close for my area. Maybe it's not a good disease. Yeah. So resilience. So
Thank you so much, Michael.
Thank you.
We should move on for your lecture. Dr. Zaki. Let's go there.
Yep.
Yeah,
I sent it to, which I don't have on here. And what's the Wi-Fi we're using? Unifesp Wi-Fi?
yeah.
Is there a password?
No. Oh, Unifesp, yeah, try convidados. You have Unifesp convidados. Wi-Fi melhor para entrar. Convidados. É dessa. É esse aqui, né? Here.
Yeah, I got it. Not be different.
Could not try convidados. A outra linha do Wi-Fi. Mas aí eu pensava.
What Wi-Fi did you use?
The set like universities. So, Unifesp, yeah. Unifesp on the fellows.
Yeah, that's what I tried.
The professional.
Oh, there it is. Okay.
So. So that's Hitosh Peter is joining us for 2 days, almost 3, right?
3 days. Yes. Yeah.
He's coordinator of the residency program at UIC, University of Illinois at Chicago, and also the head of the neuro-ophthalmology service there.
Yes.
Thank you.
Thank you. Thank you for having us. We're excited to be here. Usually we do an exchange where about 3 of our residents come at once, but 2 of them had conflicts. So Michael is here with me, with his program director, but you'll meet a few more of them in the spring.
We are always helping residents.
Yes.
In
Yes.
this place.
That's right. Okay. So I wanted to take some time today to talk about ischemic optic neuropathy. So there's 3 versions that I'm going to talk about. So NAION, and then ischemic optic neuropathy from vascular origin, and then arteritic. And then for NAION, how often do you think you see that here? Is that relatively common? Yeah. Okay, that's good to hear, because I gave this lecture in Rwanda in Central Africa a year ago, and I started with that same question. Their response is, yeah, no, I don't think we see that at all. And so that surprised me, but it's true. And I'm going to point out one thing with the data that I'm going to show you is that a lot of the data about this has been done in Caucasian, American, Western, European populations. And so do we really understand what this looks like in different types of populations? So in Rwanda, for example, maybe the occurrence is not as high as we see in America or what you see here, but I'm sure it's not 0. So it's the most common cause of unilateral optic neuropathy in patients over the age of 50. So you really have to start thinking of that. Patients who suddenly lose vision and they're over 50 with these risk factors, vasculopathic risk factors, nocturnal hypotension is a risk factor. And then this disc at risk, which you see here, which is the nerve that is very small and crowded, which we think can choke itself off. And then another risk factor are things like Viagra and PDE5 inhibitors. So a lot of the data about the natural history of this disease comes from the ischemic optic neuropathy decompression trial. Again, this was done in the United States, and about almost half of them were women. But look at the small number that were minorities. So again, the data out of this really talks about a Caucasian population, and how well can we extrapolate that to other populations remains at least not as clear. And this study was looking at observation versus doing surgery to decompress, kind of like an optic nerve sheath decompression. We'll talk about the results of that study in a moment, which you all should know. But because that was in neuro-ophthalmology, this is one of our classic studies. We're not quite like retina that has scores and scores of studies, but in neuro-ophthalmology, there are a few landmark ones that you should know. So this provided important natural history about NAION. It used a standard definition of ION and evaluated patients within 2 weeks. These patients have no pain, and they very often will tell you, oh, I woke up and suddenly I couldn't see. I was blurry in part of my vision. Importantly, many of these patients have reasonable vision. About half of them are better than 20/60. In the US, you can drive with vision like that. And the mean deviation, however, was about -18. And it tends to be an altitudinal defect, but it really can be any variation of these. The nerve can look a lot of different ways. You have mild disc edema. You can have segmental disc edema with hemorrhages, cotton wool spots, and luxury perfusion. So all of these are signs of an ischemic process. Now, very often the segmental disc swelling will correspond with a visual field defect. So superior disc swelling corresponds to an inferior altitudinal defect. And this swelling then within 6 to 12 weeks will turn into pallor and atrophy. So there's some interesting anatomy behind why this presents the way that it does. The pathogenesis has to do with these posterior ciliary arteries related to systemic microvascular disease, this crowded nerve that squeezes a little bit too much, and nocturnal hypotension that doesn't provide enough perfusion pressure into the nerve. Hay-Ray is an important neuro-ophthalmologist in the United States who studied this quite extensively and found there's between 1 and 5 of these posterior ciliary arteries all the way around the nerve. These then branch into short and long posterior ciliary arteries. And the important thing to know is that these are end arteries. So the space between the arteries is a watershed zone. And if you don't have enough pressure, that watershed zone can become ischemic. And that's what leads to this segmental disc edema. And the most common location for that watershed zone is superotemporal on the disc, which is why very commonly you get superior disc edema with an inferior altitudinal defect. This is the anatomy that explains that. Very commonly patients ask, well, what's my risk of a stroke? And other doctors will ask, what other testing do we need to do? There's really no evidence for an embolic or vaso-occlusive event. There's no occluded carotid vessels. It spares the cilioretinal and choroidal circulations. And so the natural history, fortunately, is that many of these patients will gain some vision. They'll improve depending on the study. So the IONDT at 3 months and 24 months, about a third, maybe up to a half of patients will get visual improvement. So that's good for you to be able to say. That's hopeful. Patients feel good if you tell them there's a chance they can get better. Visual worsening, though, depending on the study, again, maybe about 20% might actually lose a couple more lines. And that's also important for patients to know so that they know what to expect. And if the vision blurs by a couple more lines, that is possible. The visual field, importantly, does not change. So the visual acuity can get better or worse, but in the studies, there's been no change noted in the visual field. So vasculopathic risk factors make things worse. The edema resolves in 6 to 10 weeks. They tend to develop pallor, but not cupping. It's something that I classically teach, but I've seen patients who get cupping from that. The important thing, though, is that there's a high risk of this happening in the other eye, 30 to 40%, depending on the study. Same eye, NAION, very unlikely, we think, because the nerve has already and is atrophic, that it is unlikely to get that swelling again. There is a risk of TIA, stroke, and MI because of these other vasculopathic risk factors. So I always send these patients to their primary doctor for a physical exam. We have tried everything to treat this disease. So neuroprotective agents, aspirin and anticoagulants, but none of these have really borne out in any of these studies. What about steroids? So Hay-Ray, we talked about him. He studied this and advocated for the use of steroids. The nerve is swollen. Is this inflammatory? And this study concluded that the use of steroids would be helpful, but both visual acuity and fields improved at 6 months in this particular study. But there were some caveats to this. It was not level 1 evidence, so it wasn't randomized. Patients chose whether they wanted to be observed or get steroids. The patients were not masked, and these was the physician. And because it was a patient choice study, I think more of the diabetics decided, you know what, I don't want the steroid, that could make my diabetes worse. So there's a lot of problems with this study. So I would be careful drawing conclusions based on this study. Even though Hey is a prominent researcher, there's some problems with these data. Here's a randomized control trial. This was done in an Indian population that found that it did not improve the visual acuity at 6 months. The edema goes away faster, so as doctors, we feel good about that. And the VER may have gotten better, but ultimately it's clinically unimportant and it probably doesn't help patients. So getting back to the study, do you guys recommend optic nerve decompression for NAION? You know, and so this is why it's not effective. So the observation group was more likely to have visual improvement than the surgery group. So it didn't help. Worse yet, the patients who got surgery were more likely to lose vision. So surgery was actually harmful. So we don't recommend this at all. So we tried all kinds of drugs. We tried surgery. We still don't have an answer. This was the most recent study. We were one of the sites for this. This was a multi-center study all over the world looking at intravitreal caspase inhibitors. Remember, we said about 20% of patients can continue to lose vision. This study was trying to see, can we intervene and prevent that additional 20% of vision loss? We thought that there was a role of apoptosis in those patients, and caspase inhibitors can prevent apoptosis. So let's inject caspase inhibitors into the vitreous to see if we can make any headway. 800 patients all over the world. And at the interim analysis, there was no benefit once again, and we stopped the study prematurely, just like the IONDT. So yet again, about 30 years long, we've been looking for an answer with major studies on this condition, and we cannot find one. So still, unfortunately, there's no proven treatment. I tell my patients to manage the vasculopathic risk factors, evaluate for sleep apnea, right? Those are modifiable risk factors. Avoid nocturnal hypotension. I used to tell patients, don't take your blood pressure medicines at night. We now in the neuro-ophthalmology community are leaning a little bit away from that. You need to treat your blood pressure the way your doctor says. I think it's more important to treat these top two. One quick thing about, and Michael mentioned this when we thought about it in our patient who was 35. It's really unusual under the age of 50, but not impossible. In these patients, however, we should think of a few other things. And so I do check antiphospholipids, hyperhomocystinemia. Those have been found to be causes of NAION in younger patients. And I don't know how much you talk about this, but there is a risk of NAION after cataract surgery. And patients have come to me after they had cataract NAION. They're talking about cataract in the other eye. They're like, should I do it or not? And this study from 2007 kind of looked at this. And the numbers are not great, right? Only 17 of these patients. But it turns out that the risk is much, much higher in eyes that get surgery than eyes that don't. So what do you counsel your patient? I present them with this data and I allow them to make the choice that they want to make. Because ultimately the cataract surgery has a high chance of improving their vision. And while the risk is higher, it's still not that high, but 3.6-fold increase in NAION. The next one that I wanted to talk about is ischemic optic neuropathy of vascular origin. And this, I think, is a very important discussion that I worry sometimes in the general ophthalmology community that this is not clear what you need to do. So I want to be very clear. If you see this, what you should do next. Okay, so let's say we have this patient, 60-year-old, recurrent, painless vision loss in the right eye, lasts for about 30 minutes each time, no flashes, no floaters, no headache. He has diabetes and high blood pressure. And he has a cherry red spot. Central retinal artery occlusion. Do you know what to do with this patient? Right? spot. This is a normal one on the other side. Forcing angiogram showing some perfusion. This is the MRI of this patient, showing multiple areas of diffusion restriction. This patient, and this was done within just a few days of the CRAO, this patient had a stroke in the eye and has evidence of an acute stroke in the brain. CRAO is a risk factor for brain stroke. That's the point I want to make. Here's a study, a concurrent acute brain infarcts in patients with monocular vision loss. MRI done in these patients within 7 days of symptom onset. A quarter of these patients had had a stroke. Here's another study looking at the same thing. Here they did the MRI again within 7 days. Again, 1/4 of these patients had had a stroke in the brain. And many of them had no other symptoms. Eye, brain. And the third one I want to show you, here the MRI was done real fast within 1 day of the vision loss. And again, a quarter of these had acute brain infarcts on neuroimaging. And many of these had other neurologic symptoms. So BRAO, CRAO, amaurosis fugax, they all have a similar pathophysiology, and they're mostly due to emboli. From the carotid, from the cardiac are the most common locations. So what do? This is a stroke. They need to go to the stroke center. After any TIA, transient ischemic attack, the risk of stroke is 10 to 15% at 3 months, and half of these will occur within about 3 days. These patients need to go to the stroke center right away. Don't delay. A retinal TIA presenting less than 2 days after symptom onset, stop thinking, go to the emergency room. They're having a stroke. If it happens after 2 days, it's a little harder to know what to do, but recurrent episodes, major risk factors, it's a stroke. Make sure they get evaluated right away. You don't want to miss that. I don't know how your stroke centers are set up here. In the US, there are certain ones that are and other hospitals that aren't. I would say I know my stroke team very well, and if I'm ever worried, I call and I work through that with them about if, when, and where to send these patients. And I want to point out this recommendation about treating CRAO, whether it's transient or fixed, as an emergency, as a stroke emergency, is not just coming from neuro-ophthalmologists. It's not just coming from neurologists. This is a preferred practice pattern in the US, at least, of the American Academy of Ophthalmology. And here it says, for retinal and ophthalmic artery occlusions, this is from the American Academy of Ophthalmology, acute symptomatic artery occlusion from embolic etiology is an emergency, and these need to be treated as a stroke. Send it to the stroke center now. I like to use this score. It's called the ABCD score. It helps you to calculate the risk. It's not perfect because it wasn't designed for transient eye stroke symptoms, but it does help you understand what is the risk of a patient having a stroke and how emergent you should be. So you add up age, blood pressure, clinical features, duration, and diabetes. And here it can tell you then what is the risk within 2 days of having a stroke and whether this patient should go to the emergency room right now, or can this be done on an outpatient basis. So your job as the ophthalmologist is to make the correct diagnosis of ischemic ocular vision loss. If you identify that, you refer it to the stroke center. And that's all you have to do. It's pretty easy. So what is a stroke center? It's an urgent care facility that can very quickly and efficiently work up the risk factors for a stroke and start any blood thinners or whatever else it is that they need to do. They will do quickly MRI, vessel imaging, all of these things to help make that diagnosis. We're ophthalmologists, we don't do that. But you make the diagnosis and you send them to a place where they can. What else should you do? One more thing. Rule out GCA, right? We don't want to miss this because that is one of the causes of transient monocular vision loss as well as CRAO. So that's the last thing that I want to talk about is GCA. And here is a great picture because it shows this classic pallid disc edema, right? So the nerve is swollen, but it's pale. Much other kinds of disswelling tend to not be like that. Here we also see a cotton wool spot. It's an anterior ischemic optic neuropathy because of narrowing from vasculitis, and it likes the superficial temporal, the vertebral, ophthalmic, and posterior ciliary arteries. That's why patients lose vision. These tend to be of Northern European descent, frail females, much more than men. And, under 50, you need to write that up. That is so rare. But over 50, especially over 80, you really should be thinking about this in patients who have the correct symptoms. Amaurosis, transbinocular double vision, hallucinations, those are really signs of more posterior type problems. And, headache is the most common. And then probably the next most important finding is the jaw claudication. I ask about all of these other things, but really those are the top two that you should ask about, and that really would push you in the direction of giant cell arteritis. Unlike NAION, the degree of vision loss in GCA is profound and irreversible. So that's what makes this something that you really need to identify right away. So just like you'd send to the stroke center, you want to make sure you don't miss this as well. And again, we know this, we talked about this, branch artery and central artery occlusions. I think a nice test to do is a fluorescein angiogram where you can also see choroidal non-perfusion. So if you're struggling with a diagnosis, this can be helpful. It's quite sensitive and specific for giant cell. Lab testing, the ESR and the CRP. Remember, the ESR is age adjusted. So for men, it's the age over 2 is the high of normal. For women, the age plus 10 over 2. But generally, it's over 50, and most times over 100 is the ESR in patients with giant cell. And the CRP is usually 2.45 or so. Combine these, and that really increases your specificity for giant cell. And many giant cell patients have evidence of, anemia of chronic disease. So always check a CBC as well as the platelet level. Those platelet levels can go up. So ESR, CRP, CBC are the blood tests for this. This is a risk calculator Etzel Ng at the University of Toronto has created. I don't really use it, but I've told my residents about it, and I think they like to use it because you can calculate, and it helps you understand. So you put in all of these sort of risk factors, and it calculates the risk of giant cell arteritis in that patient. So if you're interested, you could play with that. Generally, we have a low suspicion for obtaining the biopsy because the biopsy is generally low morbidity, relatively easy to do. And really, you don't want to miss this diagnosis. So most of us who do these types of procedures or who have done them have a high ratio of negative to positive, and that's okay. Color Doppler ultrasound can be used. The problem with this is that you really need a good ultrasonographer who knows what they're doing to see this halo sign around the nerve. So I guess that's the question. Could we do this and avoid the biopsy? We'll have a little discussion after and see what your colleagues here think. But it can be good if you have a good ultrasonographer and a high pre-test probability. So maybe you might say, you know what, even if I biopsied and it was negative, I would still treat it as GCA. I often have that discussion with our rheumatologist. There was a discussion also about VZV and GCA, and should we treat GCA also with antivirals? I don't do that, but that's a discussion that has been in the literature. And then, of course, we can use MRI to image the temporal artery as well, where you can see this enhancement from the edema around the nerve. Sorry, around the vessel. Yes, around the vessel. Still, even though we're trying to find a way to not do a biopsy on these patients, it still remains the gold standard for giant cell arteritis. In the US, this is the American College of Rheumatology that requires, that states the reason that they don't think ultrasonography is the way forward, at least yet, is that there's a lack of technical expertise with these other modalities, ultrasound and MRI, and lack of widespread validation of these other approaches. GCA, of course, attacks medium and large size vessels, which is why you can get all of these problems in the aorta, subclavian arteries. And the temporal artery may be negative in patients who are young and don't have cranial signs and symptoms. So sometimes my rheumatology colleagues and I, we will image the blood vessels to help with that. So Doppler, CTA, MRA, even PET scanning. Our job as an ophthalmologist in giant cell arteritis is very important. And there's a big distinction, at least where I work, about how I manage giant cell and how the rheumatologist does. To the rheumatologist, this is a systemic disease of aches and pains in the body. To me, this is a disease that can blind, and it can kill as well if you looked at the other blood vessels that can be affected. So our job is to help decide how much and how we should give the steroid. As ophthalmologists, we generally think that for vision loss, we need to use IV steroid. It has better bioavailability. Not because we're going to recover the vision in the first eye, but we want to prevent the second eye. Without visual symptoms, very often a rheumatologist will use much lower doses that we think are not adequate for the eye. So that's why our input is important. We need to treat with steroids very quickly to prevent further vision loss in the same eye as well as in the contralateral eye. I mean, rarely you can restore vision. I've never really seen that. And IV has better availability than oral. I tend to admit my patients because these patients tend to be very old. They have many other comorbidities, and we want to be able to manage the side effects of steroids. And then afterwards, we discharge them on oral steroid for a very long time. And a question I often get is, how do you know how to taper it? I follow the labs as well as ask them about their symptoms. Don't delay the steroids for the biopsy. Sorry, don't delay the steroids for the biopsy. We know that the biopsy can remain positive for up to 2 weeks. And even after then, sometimes you can see evidence of healed arteritis. Do you have access to tocilizumab? No? You do, yeah. Okay, so, right. So this is actually the only drug that is FDA approved for giant cell arteritis. We use all kinds of other things, but not even steroids are really approved for it. This drug is. So, and this is a game changer because this allows us to get the dose of steroid down very quickly. Otherwise, many of these patients are on steroids for 1 or 2 years before we can safely get them off. That's not safe. So we've used other things in the past, but now this drug is the way to go. It's an IL-6 receptor antibody biologic. And really what's important is that the remission rate was much higher than the placebo group. So these patients did well. And their overall steroid dosing was significantly lower. Maybe not zero, but you can really reduce the steroid burden in these patients. So really think about this even very early in the course of treating these patients. So NION is the most common cause of unilateral optic neuropathy in adults over the age of 50. Unfortunately, we just don't have a treatment. And I showed you how hard we tried to find one, and we still don't have one today. 1/4 of patients with transient fixed ischemic retinal vision loss also have cerebral infarctions and refer those patients to the stroke center. Think of GCA in patients over the age of 50 with amaurosis, start steroids quickly and do a temporal artery biopsy, and think of tocilizumab. That's all.
Great lecture, right? Any comments? Great lecture.
Thank you.
Thank you so much.
Thank you, everyone.
Nilva, any thoughts?
So great talk, great case, great reunion. Thank you.
Yes, we are always on time. So
Oh, good.
thank you very much. We have to finish because of.
Yeah.
Are you going to stop? So, okay. So then we'll finish our meeting. Thank you so much.
Thank you, everyone.
For your lecture.
Thank you.
Everybody.